بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. So let me start by thanking my dear sisters and brothers in the Egyptian Society of Nephrology and Transplant for inviting me again and again. So in particular, Madam President is here, Ustad Dr. May Hasaballah. Thank you very much, Dr. Ayman, Dr. Amr. And I'm honored that this is the third time to be in Egypt in less than 1 month. So one more, I can apply for a passport, I think. فبدك تدبري حالك دكتورة مي بدعوة أخرى على حسابك الشخصي، على حساب الجمعية، ما إلي علاقة مشان أقدم على الجواز المصري. So I have been asked to talk about post-transplant diabetes, which, as you all know, is quite common. Post-transplant diabetes affects 20 to 30% of renal transplant recipients and up to 50% of high-risk patients. It's not only common, it's also serious. And in one recent paper published 2021, the development of post-transplant diabetes is associated with 67% increased risk of graft failure and an 87% increased risk of death due to premature cardiovascular disease. Now, worse results are definitely in recipients who were previously diabetics. So post-transplant diabetes should be actively screened for in all transplant recipients, actively managed with structured education, screening for complications, cardiovascular risk reduction, and drugs. Now, it's much more common among liver and other solid organ transplants than among renal transplant patients, and in one recent study as well. Using the same immunosuppressive regimens, the incidence of post-transplant diabetes was much higher in individuals receiving liver, 30%, compared to kidney, 19%. Most patients are asymptomatic, but symptoms are the same like any other type 2 diabetics. This is the incidence per transplanted organ and the evidence for association with mortality. So kidney transplant, 10 to 20%. There is an extensive evidence for association with mortality. And basically, those who were autosomal dominant polycystic kidney disease are more likely to have diabetes post-transplant. Liver, 30 to 40%. There is some evidence for mortality. Non-alcoholic steatohepatitis, HCV, and cirrhosis are more commonly to have diabetes after transplant. Heart, 20 to 30%. Some evidence to mortality. Lung, 20 to 40%, some evidence, and basically cystic fibrosis patients are more likely to be diabetics. These are the risk factors. Some of them are pre-existing diabetes risk, like age, being obese or overweight, race, ethnicity, diabetes candidate genes, pre-diabetes metabolic syndrome like hypertriglyceridemia and low HDL. Others, we mentioned the polycystic kidney and the cystic fibrosis. Not much of an evidence on statins or vitamin D, but hypomagnesemia probably, yes. Now, inflammation, Hep C, cytomegalovirus, HLA mismatch, deceased donor, and rejection. Drugs are quite commonly diabetogenic, steroids, calcineurin inhibitors, and mTORs. This is also a recent study, 2021, 13 transplant centers, more than 600 transplants between 2010 and 2013, followed up for 6 years. And the independent baseline post-transplant risk factors, the top two are being old and the higher body mass index. There is an association with mortality, but he did not report an association with graft failure or discensored graft failure. Timeline of risk factors post-transplant diabetes. We know that there is early and late post-transplant diabetes. Early occurs between 3 to 6 months after transplantation, and late after the first year. Early is mainly due to medications, tacrolimus, steroids, cyclosporin, rapamycin, whatever. And after 12 months, it's more towards metabolic, obesity, pre-diabetes, hyperlipidemias, and etc. So just few words about drugs. Steroids are traditionally associated with hyperglycemia and diabetes, and their effect is dose and duration of therapy related. Post-transplant steroid therapy increases the risk of post-transplant diabetes by 42%, while steroid-free regimen reduces the risk to less than 10%. They induce post-transplant diabetes by so many mechanisms, inhibiting insulin production and secretion, decrease sensitivity to insulin in the periphery, and increasing hepatic gluconeogenesis are the commonest. CNIs are the cornerstones among our transplant patients, and they cause hyperglycemia by reducing the number of glucose transporter type 4 receptor molecules on the adipocytes. So less glucose uptake in the periphery, and decrease pancreatic beta cell density. Studies report, as we all know, that tacrolimus is more to be diabetogenic than cyclosporine, and the effect is probably reversible with discontinuation of the drug. Others, sirolimus is known to be diabetogenic, and no known recognized association between MMF, azathioprine, and diabetes. So this is to sum up the immunosuppression. On top is CNIs due to decreased insulin secretion and production. Down is steroids, decreased glucose uptake, increased gluconeogenesis, and mTORs are common to both pathways. These are other metabolic effects of immunosuppression. We know that steroids not only cause diabetes, they increase lipids, increase blood pressure, and increase weight, while tacrolimus increase diabetes, increase blood pressure. Cyclosporin, they increase lipids much more, same like for mTORs. The only neutral ones are the MMF, azathioprine, and monoclonals. Now, the diagnosis of post-transplant diabetes, this is the American Diabetes Association 2021, that the criteria for diagnosis are the same like type 2 DM. Bearing in mind that transient post-op hyperglycemia is not post-transplant diabetes. They're totally different. It affects 80% of patients post-transplantation, commonly related to stress of the surgery. We should not ignore it because there are some reports that it is associated with the development of post-transplant diabetes later on. The diagnosis of post-transplant diabetes is made only in clinically stable patients. So some papers بيحكوا أقل من 6 أسابيع we can't diagnose post-transplant diabetes. Some go far ل3 أشهر. So after 90 days, you have the right إنك تحكي post-transplant diabetes, بس قبل هيك لا. We should take care that hemoglobin A1C is unreliable in diagnosing post-transplant diabetes, especially in the early stages. يعني some reports بيحكوا بأول سنة, because we know patients are anemic, erythropoietin use in some patients, and blood transfusion, they interfere with hemoglobin A1C. Criteria for diagnosis, same like type 2 DM, random plasma glucose more than 200, fasting more than 126, and hemoglobin A1C more than 6.5. So this is just to show in one study the diagnosis time post-transplantation. So do not diagnose post-transplant diabetes less than 45 days. After 45 days until the end of the first year, the gold standard for diagnosis is the oral glucose tolerance test. Next is the fasting or random glucose, and the least important is the hemoglobin A1C. After the first year, still, oral glucose tolerance test remains on top, and hemoglobin A1C comes next, and then fasting. The pathophysiology is well known, I think. B-cell damage and dysfunctional insulin release, impaired insulin-mediated glucose uptake in the periphery, and impaired insulin-mediated suppression of hepatic glucose output. This is pre-transplant diabetes, transplant-related factors, and down is the post-transplant diabetes pathophysiology. There is impairment in insulin secretion, impairment in insulin-mediated glucose uptake, incretin axis is altered, and insulin-mediated glucose production is also inhibited. Now, we have two types of post-transplant diabetes. Early, most cases, up to 80%, are observed early after transplantation, say 3 to 6 months after transplant. And up to 1/3 of them may revert into normal in the following months. Late is post-transplant diabetes, which occurs after 12 months onward, and the annual incidence of late post-transplant diabetes is the same like pre-diabetes, which is 7% per year. What does the ADA, American Diabetes Association 21, say? First, that post-transplant diabetes is not type 2 diabetes. They classify diabetes into type 1 and type 2 and type 3, which is specific types of diabetes. Here comes the post-transplant diabetes. So post-transplant is not type 2 diabetes. Patients should be screened after transplantation for hyperglycemia with the formal diagnosis of post-transplant diabetes, best made once the patient is stable, so not less than 3 months after transplantation. Oral glucose tolerance test is the preferred test to make diagnosis, and immunosuppressive regimens shown to provide the best outcomes for patient and graft survival should be used, irrespective of the post-transplant diabetes. The differential diagnosis from type 1 to is, I think, known. How to manage? Now, these are the new guidelines from the Association of the British Clinical Diabetologists and the Renal Association 2021. Post-transplant diabetes should not be diagnosed within 3 months of transplant. The optimum screening method is the afternoon capillary blood glucose. If hyperglycemia is significant, say 2 readings above 200, treatment should be initiated. If 2 readings more than 250, then insulin is indicated. So we should initiate treatment if 2 readings are more than 200. We should initiate insulin if more than 250. At 3 months, most patients are on stable immunosuppression doses and therefore can be screened for post-transplant diabetes. We should thoroughly look pre-op for diabetes. High-risk patients are if the fasting glucose is something between 100 and 126, and hemoglobin A1C between 6 and 6.4. Immediate post-op, I said that immediate post-transplant hyperglycemia is not post-transplant diabetes, but it gives us an alarm. Now, regular review of the patient to reduce steroid and stabilize immunosuppression and consider conversion to less diabetogenic CNIs, say cyclosporin instead of tacrolimus, reduce oral hypoglycemic agents or insulin if possible. Now, at 3 months, if the capillary blood glucose is well controlled, hemoglobin A1C at target, consider reduction of anti-hyperglycemic agents. If it is capillary blood glucose less than 200 and off treatment, then we should regularly check for post-transplant diabetes. Any hemoglobin A1C more than 6.5, fasting more than 126, on 2 occasions, we should diagnose post-transplant diabetes and refer to a diabetes clinic. If less, of course, this is not post-transplant diabetes. Now, this is again back to the American Diabetes Association, that an A1C goal for many adults of less than 7 without significant hypoglycemia is appropriate. So we should not go too tight in glucose control. The level of evidence here is A. And on the basis of provider judgment and patient preference, achievement of lower hemoglobin A1C of less than 7 can be achieved without significant hypoglycemia in some patients. Less stringent A1C, less than 8, may be appropriate for some patients. Now, what about immunosuppressive medications? CNIs We know that strategies to minimize or avoid CNI exposure have been shown to reduce the odds of developing post-transplant diabetes. Steroids, a lot of debate, a lot of controversy, steroid avoidance or steroid withdrawal. Induction therapy, only one study shows that post-transplant diabetes incident with alomtizumab is less than IL-2 receptors. Now, what about new or novel anti-diabetic medications, GLP-1 receptor agonists or glucagon-like peptide-1 receptor agonists? In case of post-transplant diabetes, they have the potential benefits of reducing metabolic impacts, reducing cardiovascular effects, and some effects on in the kidney. They increase renal protection. Of favor in this group of drugs that they have no interaction with immunosuppressant mediated by cytochrome P50 enzymes. These are the studies published so far on GLP-1 receptor agonist. As you see, the number of patients in each study is little, in fact, a few patients, 60 or 50, not more. DPP-4 inhibitors, in the case of post-transplant diabetes, they have a metabolic impact by repairing pathophysiologic etiologies of insulin resistance and can be used as adjunctive therapy, lowering insulin requirements. Cardiovascular effect, no studies. Kidney effects, some reports of reducing albuminuria. And these are so far the studies published on DPP-4 inhibitors. برضو عدد المرضى فيهم قليل. Now, SGLT2 inhibitors, you know, هم مصارعة العصر. هلا صارنا سنتين ما نحكيش إلا عنهم, and there are a lot of studies that prove that they are beneficial in reducing the progression of chronic kidney disease. But what about kidney transplantation? لسه برضو الستاديز عددها قليل. They have definitely a metabolic impact by reducing hemoglobin A1C and obesity. They have some cardiovascular effects by improving cardiovascular outcomes, and they improve renal function and outcomes in the graft. And these are the studies so far published on SGLT2 inhibitors. الأعداد المرضى فيهم قليلة. So we can't jump into conclusions. I will need 1 minute إذا سمحتوا لي. أنا خلصت بس دقيقة. اسمح لي. So this is a comparison between GLP-1, DPP-4, and SGLT2, and these are the benefits of the whole groups of medicines on other organ transplants. To conclude, Mr. Chairman, post-transplant diabetes is common and important complication. The development is associated with graft failure and premature death. Identifying patients and treating them is crucial. And there is controversy in the management after the 2013. Novel drugs are important to prevent complications. These are my references. Proud that one of them was published in the Journal of the Egyptian Society of Nephrology. And this is the view from my balcony قبل أسبوعين لما روحت من مصر. هيك كانت الثلوج عندنا بالأردن. وهذا اللي عملته أنا وأولادي being بنحب الهورسز. هذا اللي عملناه على باب البيت. Thank you very much.
Thank you, Dr. Mohammad. We will move the discussion to end session. شكرا دكتور محمد.
Thank you very much.